Great. Hello, everyone. Before we begin, I want to make sure that you all know that this is being recorded. And so we will eventually post this on our website for those who could not attend. However, we won't be recording the Q&A, the part where you all can speak, so we can respect your privacy. So just keep that in mind if there is any other time that you engage with our speaker. So welcome, everyone. I want to introduce the very first person that will speak in a new alumni series that the McGovern Center is going to be doing. Once a year, we're going to be inviting back some of our alumni of the mission, and Dr. Amanda Actor is one of you. She knows what you're doing, where you've been. She is a McGovern, an ex-McGovern student, ex-medical humanities concentration. So this is your time. This is about you. I have asked faculty to sort of just be in an observation role and to make this space something that is a safe space for you all to ask questions and to have a conversation while we just sit in the background. So without further ado, I am going to turn this over to Dr. Actor, who is a current PGY3 psychiatry resident here at UT Houston. She graduated from McGovern Medical School in 2020 with a certification in medical humanities and ethics. She is currently enrolled in the GME in Humanities and Ethics program that we recently offer here at McGovern Center. And her interests include geriatric psychiatry, academic medicine, and narrative medicine. So I am now going to turn it over to Dr. Actor.
Wonderful. Well, thank you, Dr. A. I'm very honored to be invited to speak with everyone tonight. Let me share my PowerPoint and get us started. I do have, I did have the chat up. There we go. So if you would rather chat instead of talking, definitely feel free to do that. And I do like seeing your faces. So if you can, or in a safe space to share your video, that would be wonderful as well. So I will be speaking tonight. The topic of my presentation is I love all my patients, except for those I don't, on finding emotional balance in patient care. So just a couple objectives for today. I will be starting off by illustrating the challenges of treating all patients with empathy and kindness, also critiquing the notion of loving all your patients the same. We'll be examining how countertransference can be used as a tool and not a hindrance in medical care, and overall expressing how narrative medicine can provide emotional balance and negate burnout. At the end, we'll be practicing journaling and examining how we look at different challenging patient interactions. And I would like to say that all patients that I will be talking about have been de-identified to protect their privacy. And if at any time during this conversation, if you have a question, please stop me. And I'm looking forward to having some rich dialogue and discussion with everyone. All right, so Dr. A did a great job. But just to kind of quickly review, who am I and why do you have to care about what I'm talking about tonight? So I was in your shoes just a few years ago, graduated with the scholarly concentration in 2020. I'm currently a psychiatry resident. And I want to say that your journey with medical humanities doesn't have to end at the conclusion of medical school. I found medical humanities to be very enriching in my medical education, as well as my career as an early psychiatrist. And I truly do love medical humanities, especially have a passion for narrative medicine, which will definitely become apparent kind of throughout this presentation. So I know we're on Zoom, and I do want to preface with everyone that while we're talking about stories, perspectives, anything shared by you or your colleagues, I really ask that it stays confidential, stays in this room or your perspective rooms. I do know that this part of our presentation will be recorded, as Dr. Ray mentioned, so be mindful of that. But if you do choose to disclose an experience that happened between you, a peer, a faculty member, a patient, I do ask that you would de-identify them just to preserve anonymity. So as we get started, like I know we're on Zoom, but if you can raise your little avatar hand or click a thumbs up if you agree with the following statements. So the first one, raise your hand if you've ever worked with a patient that you liked. Love this. Okay, my plan is working. Wonderful. So I see a couple of hands. Great. So hands down, and we'll do another one. Raise your hand if you've ever worked with a patient that you disliked. Okay, also seeing some hands. And let's do hands down again. And last question. Raise your hand if you've ever felt pressure to love all your patients equally. Great, and thank you for your participation. We can put our hands down again. So I've definitely 100% felt all of this. I've had patients that I've really liked. I've had patients that I've kind of disliked, and I've definitely felt pressured to love all of my patients equally. So in medicine, there's definitely a pressure to treat everyone the same. You know, we can have a whole discussion about justice in medicine, medical bias for another time. But generally speaking, as a whole, you know, we spend a lot of time in training learning that bias is bad, and we really need to do our best work by our patients, no matter who they are, where they come from. You know, nearly all of us choose to pursue medicine because we like helping other people. So there's that added component of feeling like we really need to go that extra mile for all of our patients, and to go the extra mile for all our patients and not just some of them. However, that's a lot easier said than done. So I want you to consider this. You got two rooms next to each other. In one room, you have a sweet old lady. In another room, you have an entitled younger man. So the sweet old lady offered me her pudding. She was distinct in telling me her symptoms. I got an easy history. She was sweet. There were no issues there. However, the entitled young man, I was getting complaints about all morning, making sexually explicit remarks about my nursing staff, and he didn't offer me any of his pudding. So what are some thoughts that you initially have? With this, you have to go talk to the family and spend maybe an extra 15 minutes late and with updates. What are your initial feelings? Does anyone have any thoughts they want to share on this?
I guess one thought I have is, well, first of all, the no pudding is a real tragedy. But when you're calling a family of this entitled young man, I find myself either looking for two things from the family, and it's either looking to antagonize the family as a reason for like why this family member who's the patient is so entitled, as like a kind of a nature versus nurture, like, oh, it's maybe not him, it's the family. Or I'm looking to find like sympathy with the family, like maybe they like, oh yeah, he's a lot to deal with. And those are kind of the two things I'm implicitly looking for when I'm having a hard time, like you described.
I love that, James. Definitely. You know, you want to find meaning behind these maybe negative patient interactions. Why, where are they coming from? You know, is this something that their family has to deal with all the time? You know, also on the flip side, maybe some frustration, like, why is this something that I'm having to deal with right now? Definitely. Any other thoughts anyone has? So initially for me, my first thought is it's so much easier to have to stay late an extra 50 minutes to talk to the family of the sweet old lady. I may still drag my feet, you know, I'm staying late, but overall it's definitely less of a challenge. So when I really sit back to think about this, and you know, I was faced with this exact dilemma, I kind of became embarrassed. Honestly, I felt like I was supposed to go the extra mile for both of them, and I'm supposed to treat them both the same. And I really felt that I wasn't allowed to like any of them differently, even though a deep part of me did. So what happens when it's more than just pudding? Hate is a strong word. I'd like to say that there are no patients that I hate, but at the same time, part of this conversation is about having strong emotions, both positive and negative, toward our patients. And I can very clearly think back to the first patient that I very much strongly disliked. I was actually working triage and I had a pregnant patient. This patient was actively in labor. They were having fetal heart tones that weren't stable. And I could also see the track marks on her arm from significant drug use. She wouldn't let anyone on the team start an IV though. She was screaming, she wouldn't stop moving, clearly in pain, and kept saying how afraid of needles she was, which I had found kind of hypocritical given her track marks. It was an overall very unpleasant experience for her, for me, for the nursing staff, probably for the baby. The baby ended up in the NICU and actually ended up switching services. I actively didn't check on how the patient was doing or how the baby was doing. This was really the first time I saw a patient in pain, and I didn't feel my heart go out to them. I really carried that weight for a while. I honestly really struggled with disliking someone who was sick, especially someone who was sick and under my care. I turned to the best way I know how to work through emotions, which tends to be journaling for me. So I sat down to journal. I remembered back to my time as an MS3 where we had to submit journal entries as part of our concentration in the humanities. Back then it was to Dr. Nathan Carlin. And I remembered it being a very profound and cathartic experience, so I decided to do the same here. I actually went back and I found this journal entry from a couple years ago, and I wanted to share an excerpt with it, of it with you. Do I have a volunteer to read? I know it's a big chunk of texts. No worries, I can read it. I am not afraid of hearing myself talk. So I titled this was the first time I saw a patient in pain and didn't feel my heart go out to them. I can literally see the track marks on your arms, and you're telling me you're afraid of needles. Please stop yelling at the nurses. We need to get the stupid IV in so we can safely deliver the baby that is quite literally halfway out of your uterus at the moment. You didn't get any prenatal care. You've already admitted to using drugs and drinking alcohol while pregnant. Why in the world do you keep asking for ice chips? Do you not see the pool of blood coming out of your body right now? Please stop yelling at the nurses and calling them derogatory names. I promise, if you let them get the stupid IV in your arm, I'll get you as much ice as you want. My eyes were glued to the fetal heart monitor. All I wanted was for this baby to live. I didn't care that at that moment, this woman was probably scared out of her mind. I didn't care that her contractions were causing her pain. I didn't care that she was homeless and probably in denial of the pregnancy as a whole, worried about how she would care for a baby without a stable living situation. I sit here typing, trying to find a way to make her more likable, for me to look past the monstrous exterior and find something that can help me empathize with her. Every time I think I found a tiny piece of humanity in this moment, I just keep seeing the drops in the fetal heart rate. Does anyone have any initial reactions to this piece? Or to the experience?
For some reason, Dr. Actor, the ice chips really sticks out to me. I think because so many times patients in this scenario, and you kind of recognize this with her homelessness and her denial, is how little control she has over the situation, and like how patients can choose the silliest, they use the word like stupid IV. And she said they're asking for ice chips, how they can sometimes choose like the silliest hills to die on. When you're like, no, like, can't you see there's this much more important hill? So the ice chips got a surprising like reaction from me when you were reading that.
Really great. That was, again, one of the things that definitely stuck out in my mind. And like you said, there was so many emotions flying around the room, and to think of something so small, such as like a frozen piece of ice, and that was going to be kind of something that took precedence over, a traumatic birth, was something very, very kind of profound in my head that I definitely struggled to come to terms with. But we'll definitely have time for more kind of back and forth conversation later. Oh, I see something in the chat. Yes. Spondana, I hope Sorry. So I feel empathetic towards the patient and towards you at different times during the entry. I can imagine myself being frustrated at this patient, but at the same time, I can't help but think that this mom didn't intend to hurt her baby. Nice. So definitely lots of empathy there. Being able to kind of process what's going on, process it in different ways towards different people in the situation. Definitely. Some of the power again of narrative is being able to take time with the emotions where you might not be able to in the moment. Working through medicine, oftentimes you're put in situations that are quite emergent or urgent, and you don't always have the luxury of processing. So being able to kind of sit back, do some journaling, some writing, some reflection is definitely something I urge everyone to consider. Thank you for sharing, everyone. So I was feeling significant countertransference. It's actually a well-studied phenomenon in the psychiatric and psychologic fields. My favorite definition of countertransference is the psychological conscious or unconscious emotional reaction of a provider towards a client or a patient. And essentially, it can be a positive or negative reaction to someone. What it did for me is countertransference. It put a name to that negative emotional attachment I was feeling. And then the journaling piece, it gave me the power to identify that feeling, accept that I was feeling a certain way about a certain thing, and really process what I was feeling. And then at the end, it helped me let that feeling go. So I do have another question. And again, we can kind of do the hand raise or the thumbs up. But how many of you have worked with a resident or maybe a faculty member, a staff member at a hospital or a clinic who maybe made a comment like, I hate everyone, I hate everything, I hate all my patients, I just hate medicine. Or maybe you worked with someone who you thought was really jaded, really numb, and, just kind of checked out, really lacked that emotional connection. Yeah, I'm seeing a couple of hands. This was definitely my experience. You can put our hands down. Thank you. So I, looking back to when I was in medical school, one of the things I always kind of peeked around at whenever I started a new clinical rotation, especially, was how were the residents kind of as a whole? What was the atmosphere like? And how many of them were what I considered to be jaded or numb to the whole experience? And I remember when I was on the interview trail, I know we have some MS4s in the crowd, is that, mid-interview trail, I remember getting the same question over and over from my interviewers. And that was, what do you think is going to be your biggest challenge in residency? Of course, you had to have a go-to answer to any good residency interview question. So my go-to answer was always being too emotionally invested in my patients. And so I was afraid of moral injury. I was afraid of burnout. I really only knew that my defense that I had was the medical humanities, specifically journaling and narrative medicine. I knew that I had that tool in my toolbox. And so I definitely want to encourage you to use your medical humanities as you go through your education, as you go through residency training, to keep yourself from that burnout, from that moral injury, so that you don't become those cold, unempathetic, jaded practitioners that are so common, and lose that art of medicine. Oops. There we go. So I just want to quickly define narrative medicine and then give another example of a time I found writing to be quite helpful in providing emotional balance when I was feeling negative countertransference toward a patient. And so narrative medicine is coined by Rita Sharon, or the mother of narrative medicine, defines it as the clinical practice fortified by narrative competence, the capacity to recognize, absorb, metabolize, interpret, and be moved by stories of illness. And I will say, while my journaling tends to involve more of a narrative medicine feel, all journaling can be considered part of the humanities. All writing styles can be very cathartic, very helpful in your processing of information. It doesn't always have to include patient care or provider care. However, so when I do use one, it's I might be using them interchangeably here. So most of you worked at HCPC or have heard of HCPC. It's one of our county psychiatric hospitals. And staff's frequently called bad words by patients. Patients can sometimes fully be delusional. They have limited filters to begin with, so it definitely can be a challenging population out at the onset. So kind of bring you back into my timeline, my history of this case. I was stressed. I was stressing out all morning. I had already spent about 20 minutes on the phone with one of the nursing supervisors, and I was essentially begging them for a text so I could put one of my patients on one-to-one supervision because I was worried about suicidal ideation. On the interview a few days before with this particular patient, they had seen my Jewish star necklace, and they had already gone into a lot of detail telling me about how I was going to hell for not believing in Jesus, and there was already kind of a tense religious aspect to our relationship. So I was already having a little bit of countertransference negatively towards her anyways. But I knew I had this bad news that I had to break to this young adult. And I didn't really know how she was going to react. I was a little worried how she was going to take the news, which is also why I wanted to get the tech with me. I actually found her in her room. She was sitting on the bed coloring, very peaceful. And I went ahead and approached her. And the first thing was her complaining to me. She was telling me how the nurse wasn't going to give her coffee, even though it's been a good amount of the day before talking about how, you know, we have set coffee times and kind of the rules of the unit. But she was very frustrated that she had to wait and was asking for some extra attention and extra resources that we just didn't have. But so I came in, I had a mission. I knew I had some news to tell her. I stilled myself, decided to rip off the Band-Aid, and told her that unfortunately the car she hit in her suicide attempt in her car accident, we were just given the news that none of the passengers survived in the car that was involved. This patient wasn't even looking at me though. I wasn't sure if she heard me, so I repeated myself. She kind of groaned in response that I was still in the room and bothering her. She told me she already knew. Her mom had actually called her half an hour beforehand, and we'd gotten the news about the same time. She made an insensitive racial remark about the family that was involved, and she said she thought about it and she didn't really care. She said that at least someone was thinking about her now. She left, went back to coloring. She wasn't delusional. She had a personality disorder, but she had kind of intook that information in the way that she had and was then expressing herself in a manner that sat kind of weird with me. I ended up leaving the room. You know, as a psychiatrist, I see suicide attempts quite frequently, and it all comes out in different ways. Everyone has depression in different ways, but I will say something that I personally work on is when people use other people as means of hurting themselves, ending their life, because it can have significant impact on kind of those innocent bystanders. And, you know, this individual had involuntarily brought an entire other family into her own battle of depression. So I went home and I realized that in order to kind of lift the dread in my pit of my stomach, so that I could continue to work with this patient, work with her family, her situation for the remainder of her hospital stay, I needed to do some reflection. I needed to do something in order to not bring that into the room with me the next time I saw her. So again, I decided I needed to journal. So there's a concept called the 55-word story, which I'm a big fan of. And the idea is essentially that you have 55 words and that's all you get to kind of portray your thoughts. Sometimes it's a nice challenge to see if you can really write something meaningful with so few words. But also it provides a little bit of freedom, at least for me, in that I know I can sit down, I can jot down my thoughts, but I'm not expecting myself to write a 4-page novel or a 400-page novel for that matter. So I will share my my little 55-word story, titled it Selfish. So selfish, a mom and daughter on their way home from school, now gone forever. You laugh and say you don't care. What's even worse is that I believe you. I can't fix your lack of caring with a vilify. Attempt number 6, who will you hurt next? Yourself or someone else? So from this, I really argue that by finding some patients frustrating, you're actually being a good doctor. You know, you're a doctor or you're in medical school about to become a doctor. You're not a robot. By allowing a humanistic element of care into your patient care, that's being a good provider. By treating your patients like real people, not just numbers on the medical record, you're going to open yourself up to feeling emotions towards your patients. That includes both positive and negative emotions all around the board. So not liking a patient does not make you a bad doctor, does not make you a bad person. However, the inability to check that frustration, that disappointment, that bias at the door does. So a way to do this and kind of help yourself not bring those negative emotions into that room can be narrative medicine and can be journaling. And so I wanted to kind of describe a little bit of my relationship with narrative medicine, journaling, and countertransference. And I now invite everyone to go ahead and open up a Word document, grab a piece of paper, and I thought we could do a little exercise together. And at this point, I am going to ask Miss Angela if she's there.
You need
or
something,
Dr.
Amanda?
Ray, to maybe if we can stop sharing medical field providers. However, it's journaling can be about anything and can be just as significant, just as important and cathartic. And then if you're having trouble with inspiration, there are a lot of places you can go. A lot of different websites have weekly journal prompt groups. One that I particularly have found to be very meaningful and helpful is something called the isolation journals. It's actually started during COVID as a forum and a place for people to go to have weekly prompts to kind of express themselves. So that is a wonderful kind of avenue if you're looking for a little extra prompting for your writing. And, you know, as in all, I really wish someone had told me it was okay to feel emotions in response to my patients. I think it's helped me grow as a doctor, even though I am still early off in my career. So today I really just wanted to give everyone the freedom to not feel like you have to like all of your patients. It is okay to also sometimes feel like your patients are challenging and maybe not feel like it is easy to go the extra mile for all of them. And I hope everyone has a wonderful kind of rest of their week. And I'd like to open it up for some question and answers at this time.
Great. Thank you, Dr. Actor.